Good morning and welcome to today's Evidence-Based Health Policy Project Capital Briefing. I'm Sam Austin. I'm the Director of the Evidence-Based Health Policy Project at the Population Health Institute in UW-Madison. It's a busy day and a busy week at the Capitol, so I appreciate everyone being here. This is the second in a multi-part series on the social determinants of health that we're calling the other half of health, an introduction to social determinants. Very excited for today's panel that will be looking at the intersection of housing and health, and with a look at research and data on access to adequate and affordable housing in Wisconsin, as well as a look at several projects on the ground in the public and private sectors that address housing and health. Before we get started, I'd like to briefly introduce the Evidence-Based Health Policy Project. Our project aims to connect research and expertise at the university and in the community into the health policymaking process here at the Capitol, and to support an evidence-informed approach to policymaking and to decision-making through public briefings like this that inform both the state legislature and community-based organizations, private sector groups that in turn inform the legislature. Growing out of the Wisconsin idea, we believe that ongoing dialogue and trust that is built between policymakers and academic researchers can enhance and elevate the work of both. We serve as a resource at the Capitol and a resource on campus through nonpartisan briefings such as this one, and facilitating interaction and mutual learning between the legislature, the university, and policymakers in the community and private sectors. Our project is a unique partnership of UW-Madison's Population Health Institute, where I work, as well as the La Follette School of Public Affairs at UW-Madison and the Wisconsin Legislative Council. I'd like to recognize Steve McCarthy, our project partner from Ledge Council, who plays a key role in making our project a success, as well as Stephanie Marburger, who's our project assistant for this year, a joint degree student in public health and public policy at UW. EBHPP is made possible by the support of our funders, which include the Wisconsin Partnership Program at the UW School of Medicine and Public Health, the UW Institute for Clinical and Translational Research, their Community Academic Partnership Corps, also known as ICTR-CAP, as well as the UW-Madison Chancellor's Office. We thank them for supporting our work to connect research to the policymaking process. We develop these events from input from our bipartisan Legislative Advisory Board, a group of legislators who represent a wide range of perspectives on health issues. Our current board membership includes Representatives Jesse Rodriguez, Joe Sanfilippo, Daniel Reamer, Joan Ballweg, Deb Kolste, and Paul Tittle, as well as Senators Devin Lemieux, Mark Miller, and Leah Vukmir. We appreciate the engagement of all those offices in the project, as well as the participation of legislators and staff who are here today. This series grew out of discussions with our office with legislative staff on both sides of the aisle about related to this model of what drives health outcomes. This is going to look familiar to a lot of folks in the room. This is developed by colleagues of mine at the UW Population Health Institute and is a model of what drives health outcomes. Obviously, clinical and behavioral factors are a big part of this, but also where we work, live, and play plays a role in how healthy our communities are. These factors, known collectively as the social and environmental determinants of health, include education, employment, income, family and social support, community safety, air and water quality, and housing and transit. The first in our series of briefings held in November of last year focused on family and social support and how cohesion and connections can affect a community's health. That briefing featured Gina Green-Harris from the Life Course Initiative for Healthy Families and the Wisconsin Alzheimer's Institute, and Lonnie Berger, who is the director of the UW-Madison Institute for Research on Poverty and is a professor at the School of Social Work. The health rankings model has housing and transit as a single block. That seemed like a lot to handle in a 2-hour chunk, so we're just going to be doing housing today. And we're excited for today's panel that will give you views from academic, local government, health system, and health insurer sectors on how this intersection of housing and health informs their work. But before we get to the panel, I'd like to welcome State Representative JoCasta Zamarripa for some opening remarks. Very excited to have her here today and share her perspective on housing and health and how she builds evidence into her work here at the Capitol. Representative Zamarripa has represented the state's 8th Assembly District, covered in the now near south side of Milwaukee since 2010, after serving in multiple roles in the nonprofit and advocacy sectors. She's a graduate of UW-Milwaukee and currently serves on the Assembly Health Committee, as well as the Committees on Criminal Justice and Financial Institutions, and is the ranking member on the Committee for State Affairs. So Representative Zamarripa, really appreciate you being here today, and
Thank you, Sam. Well, good morning and welcome, everybody. I'm so happy to have been invited to just give really brief remarks before your panel begins. I was really interested in Sam wanted to make sure I addressed this social determinants of health that you've been discussing and the conditions and in the places where people live, learn, work, and play, and how they affect this wide range of health risks and outcomes for our constituency, for my constituents. So, like Sam said, I'm JoCasta Zamarripa. I represent the 8th Assembly District, which is home to the largest Latino community in the great state of Wisconsin on the near south side of the city of Milwaukee. But it's arguably also the most diverse district, home to still many Polish grandmas and grandpas, a thriving LGBT business district. We have a lot of young professionals and all professionals moving into the Walker's Point area, which is really becoming very hip and trendy. And so it's an interesting district to represent, and it's a great honor for me and a tremendous responsibility. So being also a member of the Assembly Health Committee, it's very important that I vote and support bills that promote health equity for everyone across the board, and that will be beneficial to everybody. Promoting good health for all is paramount, and we can't forget those folks who have a lower socioeconomic status. And I know I mentioned Walker's Point and how thriving and kind of hip and trendy it's becoming, but I also represent absolutely a low-income community, a working community. Oftentimes I hear people talk about Walker's Point being kind of a gritty part of the city, and I'm proud of that. They can call it that if they want. But I think it lends itself to the fact that this has always been a working community, and it continues to be. And I have to remember every constituent that I represent, whether it's that affluent condo owner in Walker's Point, or the kid living a block away from South Division on 12th and Lapham. So I want to talk a little bit about, you guys are talking about housing today, which I think is very interesting, but we need to also consider things like food deserts and what poverty does, how it limits our constituencies' access to things like healthy foods and fresh foods. Public safety in our neighborhoods is so important. And that education is a huge predictor of health, and the better education you have, the better your health is going to be. I think about our Latino community, where I'm always hearing about the high rates. We have a high rate of diabetes. We have high rates of obesity in our Latino community, and that's something that we as leaders have been trying to address. Other nonprofits and healthcare organizations have really been working hard in the district to address that issue in our community. I think of Coral Centro, which maybe some of you guys have a relationship with in the community that's been doing great work in getting our constituents moving and encouraging us to eat healthier and eat more whole foods. And housing, I'd love to, I have to leave a little bit early, but when you guys mentioned you're going to focus on housing today, I think about the kind of the skyrocketing rent that we're seeing, in particular in the city of Milwaukee. I'm a renter, and I'm moving into that swanky Walker's Point neighborhood that I mentioned, and the most inexpensive market rate rent is $1,200 a month, and I really worry about the constituency in this working district and if they're going to be able to continue to live on the near south side of Milwaukee as we see that gentrification happening. So it's an interesting kind of conflict that I'm in right now, as I love the development and want to support it, but also I'm very aware of things like gentrification. So it's important that I hear from experts in the field like all of you. On the health committee, we have one healthcare professional, Representative Deb Kolste, a Democrat from Janesville, and she is a vitally important member of the committee. We need her expertise. She's a nurse, her husband's a doctor, and she brings that, as I said, expertise to the committee, where we have a variety of legislators, and it's good to have a diversity of opinion. I certainly, I would fear the day of when we lose Deb Kolste, and why it's so important that we stay in contact with folks in the healthcare field who are experts, because we really are not necessarily experts as state legislators. So thank you for being here. You're here in the Wisconsin State Capitol. This is your house. Keep coming back and making sure that you weigh in and educate we as legislators on the best healthcare policy for all Wisconsinites in our great state. Thank you.
Thank you, Representative, for those comments. Appreciate it. Couple quick things before we start today. The folders that you picked up on your way in have an agenda, as well as biographies of all of our speakers and a list of further resources on housing and health, as well as one-page overviews of the EBHPP and the Population Health Institute. There's also a yellow sheet floating around in there that's an evaluation form. We hope you'll take a minute to fill that out. We aim to be as responsive as possible and can't do that without your feedback, especially as we want to keep this series rolling with momentum. We want to make sure that we're doing the best we can for our audiences. So make sure to fill it out and leave it on the table on your way out. One quick thing, you'll see that the camera to panelist ratio is pretty funny today. We've got Wisconsin Eye, which is sort of the C-SPAN of Wisconsin's here, as well as folks from UW Extension for our own video recording purposes. So if during the Q&A session, if you are wanting to share a question, please make sure you find a microphone so that the cameras can pick you up on that. And without further ado, I'd like to pass it off to our panel. I'll have a brief introduction of each in turn, but there are additional biographical information in your folders. Our first speaker is Marah Curtis, Associate Professor at the UW-Madison School of Social Work and a faculty affiliate with UW-Madison's Institute for Research on Poverty. Her research focus is grounded in the understanding that housing is vital for the health and well-being of families, and we're very excited to have her today to lead off the panel. So thanks, Dr. Curtis, and take it away.
Great, thank you so much. So it's my pleasure to be here and to think and chat with all of you about something that I've been thinking about for my entire doctoral and professional career because of the pivotal importance of such. Sam gave me a very specific charge, and it was to think about the research base around different aspects of housing, the housing bundle, and health outcomes, to think about the state in particular and the housing markets, and also to talk a little bit about this community impact grant that I'm a part of. So I shall do those things, Sam. So why do we care so deeply about housing? All of us got up somewhere this morning. We care, every one of us, deeply about who we live with, who we live around, the quality and the stability of that bundle. Housing is not just a box that you live in. It delivers all kinds of other goods with it. It delivers the public services that you have access to. It delivers the neighborhoods and schools which you educate your children in. And you need that bundle and everything attached to it to actualize all the other things that we care about: labor market success, health, and education. Let's see. Here we go. Now, there is a broad base of evidence looking at the relationship between different aspects of housing and different health outcomes, so I'm going to summarize some of that for you. Okay. There is convincing evidence across place and space that suggests that inequalities in both access, the stability of the housing, and the affordability of adequate housing are related to very serious social problems, things like poor health outcomes for both adults and children, and educational outcomes for children, inadequate medical care, hunger, and homelessness. Another thing to know is that housing costs constitute the largest portion of most families' monthly budgets, particularly low-income renters. There's evidence also that the regularity of monthly income, how regular your monthly income stream is, holding your annual amount of income constant, is associated with housing stability for Wisconsin custodial mother families. There's an intuition here that's important. So certainly, of course, there needs to be an overall base of income, but the regularity and the changes in that income over time can be very directly related to how you can, and if you can, maintain stable housing. Because we all plan our housing, right? We know we have monthly bills coming. And if you cannot depend on a regular source of income, you may underinvest. You may choose less good quality housing for a good reason, because you know you can maintain it. And that's particularly the case for families with children, because moving is deeply, deeply stressful. So you could understand how you might make a decision to move into a place at lower cost and perhaps lower quality and less good public goods, because you know you can hold on to it, because the risk of losing it is greater. Now, housing and family life, this is where we do it all. We do family life based on our housing in our communities. We know that modest earning families' lives are challenging in dynamic ways that may impact consistent earnings. There's the nature of work at the low end, the regularity of such, how well that's regulated. We know that there are more health challenges for folks who are lower down on the socioeconomic ladder. And we know that we have had dramatic changes in family form over the past 30 years. So families are more complicated, living in multiple places, right? And so you have to keep all of that in account. That is what's happening in people's private lives while they're navigating a dynamic private housing market. Okay? Here's the other thing to know. We all know this, but it bears remembering. Housing is largely a private market affair. So you meet the private market with your set of conditions, and then you need to find housing within that. So the tighter the market is, the more difficult it is, with the more challenges you have, and the more unstable your income is. So you want to know, how do families fare in housing markets? So I thought I would just talk about some of the things you need to, or one might consider. And that's because housing markets vary so much. That's the one thing neat about being a transplant from other parts of the country. I've lived in New York, I've lived in Boston, I've lived in New Jersey, I've lived in different housing markets. And even within those different states, I could move from one location to the other and face an entirely different housing market, right? So knowing your own districts, your own areas, and the tightness of the market, the type of housing stock you have there is going to be directly related to the kinds of solutions that you find. There isn't going to be a solution that is going to be equally sensible across all geography, except I would add for the part about having stable and consistent income. That's always going to make a difference. Okay? So there are several things I thought we could point out about thinking about the tightness of the housing market for your local areas. You can think about something like the worst case housing needs. HUD puts those out. They do a report every 2 years to Congress, and they look at the tightness of the housing market for unsubsidized renters throughout the nation. Okay? You might look at vacancy rates. Vacancy rates are a nice, relatively handy measure to get a sense of how tight your housing market is locally. You could look at rental indexes that show you the distribution of rents across geography. You could look at the home value index to see how well neighborhoods are doing. Okay? The other thing I think it's important to think about is to think about the nature of your housing stock in your area. Like the age of the stock. Is it pre-1940s? Why that matters is we know that older housing stock houses more environmental bads that are directly associated with health. So you want to know the quality of your housing stock. How old is it? When was it built? Right? Multifamily housing stock, single-family housing stock are things that one might consider. Housing and health interact at the point when families enter this mostly private housing market with a set of personal circumstances. Okay? What is your family size? What kind of housing stock do you need? What are your earnings? Are they consistent? Can you rely on them from month to month? What kind of employment do you need? What kind of transportation do you need? Are you far from transportation? Do you have access to a vehicle? All of these considerations. Do you have school-age children? Do you need to make use of the public goods that are our public schools? Do you have an elderly family member? Right? Okay. What is your family health? So all of those unique aspects of family life come together and meet this market. Right? Now, let's look a little bit at the national picture for housing, and then we'll think about how Wisconsin fits in with that. So if we look at the most recent data from HUD between the 2013 and 2015 period, and they've been doing this worst case housing needs. It's not a great name. The report is called the worst case housing needs, and it's been tracking the tightness of the rental housing market for like well over a decade, right? And so you read it every year, those of us who do this. It's never a pretty story. It's always quite depressing because the worst case housing needs have been consistent, affecting millions of Americans over time. So this last bit of data is no different. Worst case housing needs persisted at high levels across all demographic groups, household types, and across all regions. Okay? When we think about these worst case housing needs, they're defined as renters with very low incomes. And low income in this context is generally defined as those at less than or equal to 50% of the area median income. And folks who do not receive any government housing assistance and pay more than half of their income for rent or live in severely inadequate housing conditions. Now, the important thing to note about this is that severely inadequate housing conditions are not the majority of these worst case house needs. It's the affordability. So here's a picture. Pictures are indeed worth many words. So it's just a time series looking at data and the growth of how many millions of families experience these worst case housing needs that are primarily driven by affordability, paying more than 50% of their income for housing, which leaves little income for other things, right? And so if you look from 2005 through 2015, you see a growth from 5.99 million up to 8.3 million. Now, I would draw your attention to the fact that if you look during when we had our recession, right, and we look towards our recovery, 2011, 2013, we know that unemployment did not remain high. However, you see that worst case housing needs do not decline significantly. So even with a return to the employment sector and decreases in high unemployment rates, this affordability issue persists. So 8.3 million, this is the most recent data, of folks are experiencing worst case housing needs. So is Wisconsin an exception? No, it is not. National data substantiates affordability for low-income renters as a national problem, and this state is no exception to that trend. So, okay, let's think a little bit about the state as a whole. The vacancy rate for Wisconsin just last year was 4.5. So this is the proportion of the rental inventory, of the total rental inventory, which is vacant and available for rent. Now, these are units at all price points. That's everybody. That's you and me and Oprah and everybody in the housing market together, okay? So if you're thinking about units that are affordable and available to folks lower down on the income distribution, there would be less units available than for those with more modest incomes, like the story that you started with, yeah? Now, here's another way. Let's think about rental costs. I just picked some areas. This is the Zillow Rent Index. And so what these numbers represent are midpoint estimates of rent in an area. And I'm glad to know that they seem pretty good, because the Milwaukee Metro rent midpoint at $1,364, and that's the midpoint. That means that 50% of them are above that and 50% of them are below that, right? And Madison, it's about $1,400, and Fitchburg about $1,600, and Portage about $1,000. So you know what the incomes are of the working folks in your various regions and whether or not this would be affordable for them. This gives you a sense of the diversion in the affordability of housing in the rental market for folks. Okay, so a little bit about the research base, what we know, and it's intuitive. You all know this in your own lives, that income is a key factor for determining both the frequency and the types of moves that households make. Not all moves are bad, some are awesome. You're moving, you're coupling, you're marrying, you're doing something great. You're getting a better job, right? So you can't just look at moves and say, oh, all moves are bad, some moves are good. So you have to have a way to distinguish whether or not the moves you're observing are problematic, okay? We know that folks lower down on the income distribution are less likely to move for upwardly mobile reasons. They're more likely to move because of job losses, family dissolution, okay, or to find lower cost housing. Okay? We also know that adequate household income and income growth are associated with moves to higher cost and quality, right? So there are levers in there. Now let's think a little about the implications of instability for families. Some research that I've done using Wisconsin data, looking at custodial mother families, using data at the zip code level, revealed a level of moving among custodial mother families with school-age children that I was quite shocked by, that the national data can't show us because it doesn't collect that. And you have to think, folks who are mobile, you're not going to capture in surveys because they're moving. So when you go back to capture them again, you can't get them. So the zip code data that we used at IRP enabled us to see short-term moves, particularly for low-income renter custodial families. And there is an amazing amount of moving at the low end that we don't actually know and we don't actually capture. The moving might be right next door. The moving might be right down the block, but you're still having to move, and it's still disruptive. And we don't capture that in our national data. You need different kinds of data to capture that. So what we know nationally about studies investigating the effects of high residential mobility on child well-being, okay, this is a whole body of research. We know that children in the most mobile households may fare worse than their more stable counterparts, even when controlling for demographic, economic, and child-level covariates that are associated with the likelihood of moving and also their child outcomes, right? So that's important. Even controlling for those things that you know would affect both mobility and child outcomes, maybe parental behavior and other stuff, when you hold those things constant, mobility, high levels of mobility don't return good things to the children in those families. So here's another point that I thought I would offer to you. So we've been talking a little bit about one way, how mobility and how health and the quality of the housing may impact outcomes for children and families. But there's also a growing evidence of there being the opposite pathway. Now, we've all heard these anecdotal stories about someone who has a medical problem and financial ruin and they lose their housing. And you wonder, are these anecdotal things actually accurate? Do they bear out? Well, there's a growing body of literature that shocks of that sort, they could be health shocks and other shocks, can indeed be strongly associated, and some might argue causally associated, with things like homelessness, right? Okay. So I'm just going to talk about a few studies. Using nationally representative data for cities with populations over 200,000, so you wouldn't want to think about this for cities that are not of that size. These are useful results for similar cities. We find that poor child health increases the likelihood of both overcrowding. Overcrowding is generally thought about in terms of people per bedroom, and homelessness. That may also increase the likelihood of having inadequate utilities and general poor housing quality. Now, the reason why overcrowding matters for children in particular, it's not just the obvious things, that you don't have personal space. It's that you can't control the stimuli. If you don't have a place to study and a place to have your own ability to manage your homework and all of that. So crowding actually really does matter in terms of children's educational outcomes. Now, in a follow-up study, we find that having a child with a severe health condition increases the likelihood that the family experiences homelessness, but this varies by policy mechanisms, okay? It varies by whether those families reside in cities with high fair market rents. Fair market rents are just a measure HUD uses for a rent that's affordable at the low end of the distribution. So in cities with high fair market rents, in states with less generous public assistance, and among individuals who live in poor neighborhoods. So another way of saying that is that you can have a family with exactly the same characteristics in a state or a city with lower fair market rents, with more generous public assistance, and you would not necessarily see the same level of homelessness. Additionally, we find that receipt of housing subsidies, which are quite scarce. Those of us who think about housing know that the availability of housing subsidies, which lessen your rent by about 30% of your monthly income, are very, very scarce. They're a very valuable benefit, but very, very few people get them. Okay? The receipt of housing subsidies, temporary assistance for needy families, the cash portion of that, and SSI, supplemental security income, appear to mediate the effects to some extent. Okay? Okay. Now, I just want to put these few studies in context. Okay? Most families do not have children with a severely limiting health condition. That was not the point of the study. The point of the study was to investigate whether what we call a life shock, an unexpected shock, like having a child with a severely disabling health condition that is not associated with parental behavior. So we're not talking about like fetal alcohol syndrome. That's important because we want to talk about the behavioral aspects, okay? So this health shock is not about parental behavior. It's somewhat random in the population. So then you can not worry so much about parental behavior that affects kids' outcomes and also housing choices, okay? So that's why I did that paper, because the number of people who have children with poor health conditions of this sort are rare, but it gives you some window moving towards causation around thinking about these levers. Okay? So I'm arguing that evidence in this direction suggests that helping families at the low end contend with shocks, financial shocks and health shocks, can increase housing stability. Now let's talk a little bit about the nature of housing. Even though I said earlier that most of the worst case housing needs are driven by affordability, if you look at national numbers, and this is really important, right? If you look at national numbers about our housing stock, you'll find that 95% of our housing stock nationally is awesome. It's high quality. There's very little substandard housing. However, those of you who are working in different communities may see a really high level of that, and that's because those who live in poor housing quality stock are disproportionately in older industrial cities and in places with older housing stock that is also disproportionately inhabited by low-income families and mothers and children, okay? Now, in terms of housing, there are a whole host of studies, I cite some of them for you here, across, within the country and across country that find positive associations between markers of low-quality housing and poor health outcomes. That would be stuff, obvious things, like asbestos, lead paint, rodent, dust mite, cockroach pellets behind the wall, lack of heat and mold. Older housing stock, as I said earlier, is more likely to harbor these environmental bads. And like I said before, though severely inadequate housing is uncommon nationally, low-income households are disproportionately more likely to experience these types of housing problems. And I've come to learn in my work on, that I'll talk about later, that Milwaukee has a good proportion of relatively poor housing stock. So that means it's a great place for me to be doing this research and for you to be doing the work that you're doing. Yeah? I'm going to talk a little bit about mental health and housing. I've done some work on the other side of it, thinking about health and that impact on housing. And there's evidence that maternal depression, which is relatively random in the population, by that I mean that if you're looking at the entire populations of births and mothers, that it's relatively random who gets maternal depression. Yes, people who have a background of family depression may be more likely, but there's a real strong random component to maternal depression. So it was interesting to get to look at how that might impact housing. Okay, so what we find is that maternal depression during the first postpartum year is a significant risk factor for inadequate child living conditions. Now, all of you who do early childhood development and all of that and know about the research during the first year, how important that is, the things that parents do, in particular mothers do with children, you might think that depression in that first year could be low-hanging fruit and would be particularly important. Okay? So what we find in several studies, under the conditions of stress, families may trade off between food and housing needs, while others are driven into situations of multiple hardship simultaneously. So this study suggests that policy domains like health and housing and food security work collaboratively to think about these families, because that will most effectively meet family needs across the different systems, rather than thinking about people. We are not siloed. We're unified beings, as are the families that we work with and represent. So now is the bit where I talk a little bit about the Healthy Housing Initiative, which is a WPP Community Impact Grant. I'm very excited that my community partners are here in the audience today. I didn't know that. Where are you? You're here. Hello. So they're from Community Advocates Public Policy Institute in Milwaukee, Wisconsin. It's been just an incredible pleasure to work with the organization. The other academic partner on the grant is Geoff Swain from the Department of Family Medicine and Community Health, who has expertise in health and community health, and I have expertise in housing and health. And so it's just been a great opportunity to do what I do in a university, but work on the ground. So this Healthy Housing Initiative is a $1 million 5-year grant. The overall project goal is to create conditions for local, state, and federal policymakers to improve current policies that can increase housing affordability, quality, and stability. Notice I don't say housing policies in there, okay? Because it doesn't have to be a policy with housing in the title if you're able to stabilize these other aspects of family life. Okay? The goal of the project ultimately is to improve the health and well-being of low and moderate income Wisconsinites and their families. So the project methods, there are 3 different tiers. We're in the first year now. We're going to conduct a health impact assessment with an organization out of California. And what that will do will allow various actors to understand how their work, domain, and expertise are related to health outcomes. You know, sometimes I talk to folks and they may be working in a particular area and they don't think that their work, because they're working in food security or they're working in another area, they don't think it has anything to do with housing. But anything that can stabilize income or that can meet a need can allow families to negotiate that. And so part of the project goals that I really appreciate is this idea of making things that might not be obvious to folks working in these various systems who might not think they have a lever, but they might have a lever. Okay? So we'll conduct this health impact assessment, and we will create a tenant advocacy council. This is very exciting. Community input, create relationships and collaborations with and by those affected. Because like I said, there's a lot of variation in what's happening on the ground with housing and what families are most concerned about. And it would be wrong-headed to think that a strategy developed in one place might be wholesale useful in another. So you need community input. You need folks who are working on the ground to understand what's the right lever to pull at what time. And then the final pillar is to broadly disseminate the results of this health impact assessment to all stakeholders, to incorporate it into public understanding and into people's ways of working. Again, there may be levers you have at your disposal to pull that are in the best interest of Wisconsin that you didn't even know existed because you hadn't thought about it that way. So that's what's most exciting to me about the project. The other thing that I wanted to say is that the project focuses across the state. So this is a map that I borrowed directly from my partners, looking at the different organizations that we are already partnering with. Again, like I said before, because the housing market is going to vary across space and place, and maybe one area has an issue with quality that is different in tone than another area. You need the community and the tenant advocacy council, as well as these different actors, to help you understand what levers to pull. Now, here's my last few words. In terms of the policy framing, Housing and health are local phenomenon. Okay? Solutions will vary based on the market tightness, the quality and type of stock. Is it mostly single family? Is it mostly multifamily? Is it mostly rental stock, right? Okay. The population demographics, who are we talking about? And the local and regional stakeholders, even your regulatory stakeholders who are overseeing the quality of housing. So in terms of policy recommendations, I think we can pull from the evidence both nationally and locally, is that stabilizing income stabilizes housing. However, the mechanisms to do that can be varied. And in terms of those of you who are interested in housing construction and maintenance of new units that you might be part of causing to happen, like in your area, housing construction and maintenance, once you get it funded and you figure out how to do that with a low-income housing tax credit, whatever else you do, I know it's a big deal. The trick is always, and this is nationally, how it remains affordable over time to low-income renters when producer incentives expire and when tax benefit incentives expire. It's often lost to the market. And so when you read this literature, it's just a constant concern about the fact that you can create new units, but they don't remain affordable over time. And so the problem doesn't ever get solved. Finally, family health shocks and mental well-being also directly impact housing, those of you who are working in the health domain. So perhaps we might consider on well baby visits, they're all, anyone who has a new kid knows that you spend half your time at doctor's appointments, okay? You're there all the time, right, for your well baby visits. So perhaps including maternal screening for depression during that time period could be useful, asking about housing situations, and if detected, things around depression, a recognition that living conditions may become unstable, and there are serious implications for the children and the family. Families meet housing markets, so policies that strengthen health by recognizing this interdependence, I would argue, are quite primary. Thank you.
Thank you, Dr. Curtis, for that talk. I think we probably have time for one or two questions before moving on. If there's any questions from legislators in the room, I'll recognize those first. Senator Bewley?
Thank you very much. I appreciate all your comments. It was very interesting when you were talking about the link between housing and other factors, and I don't think you were suggesting cause, but you were putting things like the health well, I'll just take health, leads to unstable housing and other factors, or at least could be a predictor of it, when typically when we're having these conversations, it's the other way around. We say, could you tell me a little bit, or just kind of illuminate why you have flipped it in that way?
Thank you for the question. Part of it was this recognition, just the same anecdotal stories that we all have heard, in popular media about people losing their housing because of a health condition. This became interesting to me. At the same time that I learned about maternal depression, I learned about how really random it is, that it's not super predictable in the population. So from a research point of view, that randomness is super useful, okay? So when I put those two things together, and then I had an opportunity with nationally representative data, I could look at something that would be considered a shock, a health shock, an unexpected occurrence or in health, and how that unexpected occurrence would influence housing. The reason why the unexpected occurrence is particularly useful, particularly in policy research, is because you can get closer towards causation. And I say that very carefully, but because particularly in these several studies with the children with the severe health condition, we had pediatric doctors come in and code the different health conditions, right, on a grid. So we only chose health conditions that were not associated with parental behavior. The reason why is because many folks can argue, and there is a truth to the fact that both poor health and negative child outcomes and also poor housing can be driven by something that we can't observe. And if we can't observe it, it's harder to say that policy can do something about it. So the fact that this exogenous, outside of the family's health shock could lead to homelessness gives us a strong base to argue for policy intervention, because it doesn't have to do with behavioral things. Does that answer?
Mm-hmm. And if I may, just to follow up, when you were talking, you used the word shock, which sometimes people are using in place of trauma. I'm not sure if that's
that's
a
interesting.
choice. But when a shock occurs, the supports or the resiliency that is often used to mitigate the effect of the shock. Do you know of any studies where housing is seen as a part of resilience in trauma-informed care?
Well, I don't know about the trauma-informed care, but there is a pot of literature that looks at housing, home ownership as a protective factor. If you have gotten your home under sensible terms and you have equity, because then you could borrow against it in times of downturns. There hasn't been as much research post-recession, but I haven't seen work around trauma-informed care specifically, but I haven't looked either. You're welcome.
I think we'll probably, hopefully have a chance to, at the end, have a question for the panel, but I think we'll probably keep moving on. Sorry about that. Our next speaker is James Mathy from the Housing Division of the Milwaukee County Department of Health and Human Services, where he's the administrator of that division. He has over 20 years of experience working in the housing and community health field with a focus on the development of homeless programs and permanent supportive housing. You'll notice in your agenda that it indicated that Mr. Mathy would be presenting with Robert Itzen. Unfortunately, Mr. Itzen's not able to join us today, but I do wanted to thank him for his involvement in preparing for this briefing, his willingness to share some of his experiences, and his work with the Resident Advisory Council with Housing First Milwaukee. Take it away.
Thank you very much, Sam. Thank you all for being here today. As a housing advocate, it's a special day for me to be able to talk about this topic in front of everybody that cares about health and healthcare, and I think there's some exciting things you'll hear from UHC about some of our new partnerships. So this is a very important topic for those of us in housing dealing with homelessness. So I'm going to touch today on Milwaukee County, our housing division's plan to end chronic homelessness using the housing first approach. And when you see the words functional zero, that's actually a HUD language, but it's very important to this conversation. Pretty much means that when you're ending chronic homelessness, it means that you have enough housing stock to basically instantly house every chronically homeless person on the street and put them in housing. So if you see that term, that's what that means. So I'm going to start by talking about the words housing first. So one of the big takeaways from today as it relates to health and homelessness in general is the number one solution to homelessness is permanent housing. So when this is debated throughout the state of Wisconsin, we talk about policy changes, we talk about investments. If your number one investment is not permanent housing, you are not going to decrease homelessness in Wisconsin. So that's one of the most important things I want folks to take away from this today. So again, it is a housing problem. We believe in our division, Milwaukee County, housing is a right to which people are entitled to. And again, providing permanent and independent housing without prerequisites to treatment. So again, when we're talking housing first, that means we're talking taking individuals directly off the streets. I think the average age of our first 100 participants for being on the street, they were homeless for 8 years, literally sleeping on the streets. So the most important thing for them is getting them in permanent housing, and then we wrap services around them after they're in housing. There's no prerequisite to treatment. Folks don't need a psychiatrist. A lot of the individuals sleeping on the street have very serious substance abuse disorders. We're not asking them to go to treatment and go to detox and go through all these steps before they get the dignity of housing. We flipped that now. It's been very, very successful. So again, placing an individual as quickly as possible into permanent housing is our goal. Again, we offer 100% of the individuals in our program wraparound voluntary services after they're in housing. The goal is to remove any major obstacles to obtaining and maintaining housing. That's housing searches, that's income, that is getting folks on SSI, that's getting people employed if they are ready to do that. Whatever it takes, whatever obstacles people have to get into housing, it's those wraparound services and our community intervention work in our division that does that at the offset. And again, the opportunity to secure housing rather than having to earn it. And that's when folks are learning about housing first and looking at the way that we dealt with homelessness, say 10 years ago, this is hard for folks sometimes to wrap their mind around. Why in the world would we give somebody free housing? They should have to meet these prerequisites. They should have to be sober. And why do we do that? And you will see in my slides coming up, why we do that. So we strongly believe in our mission and the dignity of housing, but if you look at the cost savings, the Medicaid savings, the decrease in jail days and our criminal justice costs, it is night and day when we're looking at the cost of providing housing versus the cost of emergency services in our community. So we can certainly look at it that way as well. So again, key principles, as I spoke about, immediate access to housing. And again, we take individuals right off the streets that have never been in their own apartment before, and we give them keys and we move them in, and we wrap very complete services around them after the fact. Autonomy, personal choice. A majority of our housing units in Milwaukee are scattered site vouchers. Our individuals get a housing voucher, they can go anywhere they want to. It's not just the worst areas of Milwaukee or where the rents are the cheapest. If folks want to move in the suburbs, if it's a homeless family and they're concerned about their school district, they're able to move to suburbs with our help finding units. Social and community integration, we try to build communities around some of our project-based type living. We bring supports in there, try to make people feel like they're a part of the community and not just being isolative. And then community development, this is another important aspect when we're looking at new construction for homeless projects, those different types of things. One of our earliest adopters in Milwaukee for our homeless initiative was the Downtown Business District. So they're a huge supporter of our Housing First initiative. We've seen a huge drop in homelessness in downtown Milwaukee. The reason why is because of Housing First and our outreach efforts down there. And the business community is our #1 supporter. They're now giving us donations. They're calling my staff instead of the police when they have nuisance behaviors downtown. It has completely changed downtown Milwaukee because of this initiative. So major themes of approach. So how do we succeed? How can other communities succeed working on ending homelessness, but specifically chronic homelessness? Housing subsidies for permanent housing, and when you work on that, do it more. So this is the #1 thing that our community needs to do a better job of. Dr. Curtis mentioned housing choice vouchers and the scarcity of subsidies. It is a very scarce resource. I would challenge our community and our country to think about that a little differently, local or federal level. And again, we've got some creative ways that we can do that as a community. Again, even at the state level, there's been some wonderful conversations about homelessness at the state level, and that's really, really encouraging. Again, if we don't talk about permanent housing in those debates, we're not going to see our homelessness numbers in the state drop at all. So that's the #1 tenet to this. All of our individuals have some form of a rental subsidy, either through our division or through the local Milwaukee Continuum of Care. Case management services. So we have various case management services. Every single person in our Housing First initiative does receive case management. So in a perfect world, they're Medicaid eligible, and they go to our Milwaukee County Behavioral Health Division, and they receive community support program support, targeted case management, Medicaid waiver programs, and that's great. So if a person wants to enter recovery services, they want to see a psychiatrist, they want to take medications, they want to do those things, they go into our traditional case management system, and that's great. What we certainly have found, and one of the reasons we started this, is the majority of the folks on the street did not want to do that. They would choose to live on the street before they accessed these very clinical services that they did not want. And the old way of doing that in a lot of communities is, well, until you're ready for that, you can stay in the shelters, you can stay on the street, call us when you're ready. And that just does not work. So we actually have a different type of case management now within the housing division. We actually provide case management within our division, not just housing. It's called Housing First Case Management. So we don't worry about what's billable for the Medicaid. We don't worry about what your treatment plan looks like. If you get into housing, our goal is that you remain in housing, you remain out of the hospital, you remain out of jail, and you tell us what you want your plan to look like. If it's bus tickets or employment or a ride to the grocery store or reconnecting with your grandparents, that makes no difference to us. And we're really, really flexible about that. So what we found, we've served well over 700 individuals, and 100% of them have accepted voluntary case management. So for a lot of clinicians that I work with, the goal is to get folks in treatment. Eventually they'll get there, but it has to be on their terms. That's another big proponent of Housing First. Outreach and staffing, we started our own homeless outreach out of our division, which is a little different for government to do that. But to really ensure the outcomes that we're looking for, ensuring our success, we wanted to help take the lead for homeless outreach. So all of our faith-based providers, all of our nonprofit outreach providers all meet with us in our office on a monthly basis with the Milwaukee Police Department. We organize every single area of Milwaukee County, working with the police where homeless encampments might be, making sure faith-based groups aren't working with the same client twice. We share all of our information to make sure all of our area is covered, and that's really helped dramatically reduce homelessness in Milwaukee. Additional supportive housing developments, again, we do some project-basing developments as well that I'll get to a little later. Coordination of resources, so we've gotten to the point now where our whole entire system, including our permanent housing resources, all go through what's called coordinated entry through our 211 system, which a lot of communities have. Ours is kind of on steroids at the moment, so every single referral, even ours coming off the street, all go through coordinated entry. We work with our coordinated entry provider once a week and go through every single homeless individual on a list in order. We know exactly where they are, we know where they're connected, whether you're chronically homeless or not, and all that's done through a very highly coordinated process. Wide range of community partners, again, part of this was getting the entire community to think differently around this housing first philosophy. And we have a lot of different partners that you might not think. One of our earliest adopters that we work with all the time is our district attorney's office. So we meet with the downtown business district again weekly, and the district attorney's office is there. They've even gone out on homeless outreach with us, waiving people's warrants on the street so they didn't end up in the court system. Very, very expensive to take somebody with no income throughout the entire court system. They can't pay fines, they have no money, and they cycle in and out of jail on very, very small municipal violations in downtown Milwaukee. Our police then see the same people on the same streets over and over again, and that never changes. So we have the district attorney's office, the police department, downtown business district, Marquette University, all these different areas that had really severe homeless issues in Milwaukee aren't seeing those folks around as much anymore. So they were early adopters. Now they're financially participating and doing a lot more work around that. So this is an example. Again, most of our housing is scattered site. That doesn't work for everybody. And if we're serious in communities about ending chronic homelessness, you have to have a lot of different models and some pretty intense ones. And this is our example. There's very few like this in the country, actually. So this is Thurgood Marshall Apartments. It's a 24-unit apartment building. This is what I don't like the term, but folks would know it as wet housing. So these are individuals that were chronically homeless, living on the streets with very, very serious alcohol addictions, in and out of detox. There was one individual that had, I think, 150 detox days in a year, and the expense to Milwaukee County with that was astronomical. So these are individuals, again, they kept ending up in jail over and over again. The police, all of them, knew them by name, and they weren't going to be successful in a scattered site housing development. So we accomplished this. So this was done with low-income housing tax credits, as the doctor mentioned, through WIDA, some subsidies through Milwaukee County. We subsidize the rent with 24 vouchers and provide very intensive services inside. And we deal with all these substance abuse behaviors in their housing unit. We don't evict individuals. We deal with all those behaviors in the housing unit. So if people are drinking an awful lot, we just accept that behavior. We're not going to ask people to be sober. It does not work for this population. They will be back on the street. So we fund all those services actually out of local property tax levy, believe it or not. Why do we do that? Because it's saving a ton of money. Our individuals have no need to go to detox anymore. We'll manage that right in their housing unit. Emergency room visits dramatically lower than they used to be. So especially policymakers, when they hear some of these things, we're giving away money to people that don't deserve it. And just mission-wise, we don't agree with that, but even more so the amount of money that we're saving, and I'll get to some of our slides with the cost savings, specifically about Medicaid for this conversation. It's really a dollars and cents issue also. So I mentioned the Homeless Outreach Collaborative. It's just important to look at all the different partners that are doing this. Again, I mentioned the police department, district attorney's office, medical college, healthcare providers, We have everybody now looking at this in the same way, and that was not the situation in Milwaukee. I know it's not the situation throughout communities in Wisconsin as well, but when you get everybody on the same page with a general philosophy, you will see a decrease in homelessness in our state. So briefly, where we began, so we presented this plan to County Executive Chris Abley to try to get this off the ground in 2015. Our goal was to end chronic homelessness in 3 years, which was really, really fast for Milwaukee. So just some brief numbers. We had about 200 chronically homeless individuals on our point in time count. For those of you that don't know what that is, HUD kind of has you count homeless individuals once or twice a year. The individuals that are sleeping on the street and in your homeless shelters, we've gotten very, very scientific in Milwaukee, where we're pretty confident of our numbers. 3-4 years ago, not so much. So we started with a number of 200 chronically homeless individuals. And again, these are the most difficult to house. We want folks off the street. We want to reduce Medicaid. We want to reduce jail days. So our first goal was to place 100 individuals within 12 months and 300 over 3 years. We are way beyond all those numbers. Number one, because it's necessary, but number two, Housing First has been extraordinarily successful. So here is one of our big slides. So these are the total number of homeless individuals in Milwaukee County. So, and Sandra and I were talking before about shelter versus permanent housing and how this is done. We have very well-meaning people in Milwaukee, always have. We have throughout our state. We have people volunteering at homeless shelters. We have people giving to different charitable organizations. And that's been great. So you look at 2007 through 2015, people continued to donate. They continued to do these different things. Nothing was changing the homeless numbers in Milwaukee County. We started Housing First with permanent housing right where that arrow is, and had one of the largest drops in homelessness in the country, quickly, from 1,500 down to 900. I put this 2018 number up. It's not necessarily public yet, but I guess it is today because I put it up there for you guys. But it is not into HUD yet. We're looking at right around 832 for our new point in time number. Will it go much lower than that? Most likely not. A majority of those individuals are living in homeless shelters, not on the street. But we've gotten that number very, very low compared to where we started, and it is directly correlated to permanent housing. And again, just our division alone, not counting our continuum of care, served about 700, 800 homeless individuals. And you can almost see it number by number with the provision of permanent housing. So here's another, so it got cut off a little bit. Sorry there, Sam, from the conversion. So this is another important thing that we focused on was the municipal court violations. So the last number for some reason got cut off on all these. So if you look at our chronically homeless individuals, we actually have a program evaluator on my team whose sole job is to do pre and post housing comparisons based on an individual's criminal justice history, behavioral health division visits, jail days, all those different things, and do a pre and post housing comparison to make sure we're telling our politicians and our funders that we are absolutely saving a lot of money. This is a big slide with that. So since the last number got cut off, you can tell with Housing First began September 2015, that 21 is actually 219. So that's 219 municipal violations for 100 people. This slide is only for the first 100 people we served. The number in 2016 dropped to 39. So we saw over an 80% reduction in municipal violations that were taken away. Why is that important? Our downtown police department should not be spending their time writing our clients municipal violations when they could be doing other things. So the police department is extraordinarily glad that we started this initiative. They are not seeing these individuals downtown anymore. If they do, now the police officers have somebody to call. There's no reason to write very, very low-income individuals tickets. Work with our division, call my staff, we'll be there in 45 minutes. We're close to downtown anyway. So that has been a big thing for us. Here's the big slide for why we're here today and how it directly relates to health. So this is a slide that has to do with savings, Medicaid savings, and savings to our behavioral health division. So again, these numbers are from roughly 100 people. And again, we've served over 700. So let's think about that when we go over these numbers. So we saw in 4 programs alone through the behavioral health division, about a $715,000 savings in 1 year for 100 people. So this is our crisis mobile team. This is detox, psychiatric crisis service, and inpatient services. So we get, as an example, $1 million a year from the Behavioral Health Division in tax levy for Housing First. Why on earth would they do that? Here's why. So this is way more than a dollar for dollar savings for the Behavioral Health Division. What's not on this slide is any cost to the criminal justice system. So we have other data that shows if an individual gets a ticket downtown, it's the police officer's time, the call from the business to the dispatcher saying there's a homeless individual downtown. They get booked, there's that time, there's a district attorney's time, there's the public defender's time, there's the bailiff's time. It's an awful lot of money. So this is just from these 4 services, and it's also not including emergency room visits and healthcare costs and all these other Medicaid costs for just 100 people. So the cost savings to our Housing First initiative, if you did dollar for dollar, is probably a 10-to-1 savings, and people are off the streets and they remain in housing. So these are some of the justice system numbers. And again, when you look at all these different numbers, this came out of a MacArthur grant that we did to get some local numbers. So when you're giving a homeless individual a ticket, every single one of these per case and per call numbers is all combined for one ticket and one arrest. It is extraordinarily costly. So here's some current calculations. The exciting thing, I've got the point in time numbers there, 70% reduction in chronic homelessness from where we started. We are on pace this year to be the largest county in the nation to end chronic homelessness, in Milwaukee of all places. So obviously we're very, very excited about that. Thank you. And the reason I point that out is not for the applause, but to get other areas in Wisconsin, policymakers thinking about this. This is the playbook for ending chronic homelessness, focusing on permanent housing and using Housing First, looking at different ways to invest in housing to save far more money on the back end. So the cost for a Housing First unit, that's with our subsidy and case management, $30 a day. So that supports somebody with rental assistance and the wraparound case management that our division does. So it's about $6,300 a year is what that's going to cost for a rent assistance voucher with a 97% housing retention rate. Again, individuals highly addicted, very, very acute mental health issues living on the street are 97% successful remaining in housing on their terms. So again, huge cost savings there. And all of them accept voluntary case management. Again, and there's a lot of clinicians on our team that get a little nervous talking about Housing First because they want treatment and they want to know what the individual's diagnosis is and all these different things. What they come to realize is folks will get there. When we talk about social determinants of health and all the things we want our clients to do, we want our clients to get a job, we want them to do all kinds of things. But what I say in public events is, if any of us were sleeping on the streets, are we going to search for a job? Are we going to try to be clean? Are we going to find out where our doctor is? No, we want a roof over our heads, and we might want bus tickets to get to our appointments. Until we focus on that, the rest of it is not going to matter, and we all will not see a decrease in homelessness in our state. So unfortunately, Robert is not able to be here today. This is something we're also very, very proud of. It's the Resident Advisory Council. So again, we take very seriously peer support in Milwaukee County, and a lot of our initiatives are ran by our Housing First consumers. So this is our Resident Advisory Council. Robert is the chair of that. So we have individuals, again, these are individuals that were living on the street. Robert is a phenomenal individual. He actually has a master's degree in journalism. And brilliant. And these individuals direct us on policy. They will go around and meet with our clients throughout the community. They do all of our charitable work, our client picnics, and they also interview all of our clients for what they want our program to look like. And we absolutely will change our programming based on what our residents tell us. Again, it's all consumer empowerment and what that looks like. So Robert has a long history of editing, so he did our quarterly newsletter. I really wish he would have been here today. This was a challenge for him to speak about these issues this publicly. So this came from our homeless individuals' minds to do this. So this is their quarterly newsletter. It reads like a magazine, comes out every quarter. Maybe I can get, Sam, maybe I can get you the electronic version of this. We're going to do this every quarter, and they interview policyholders. Robert interviewed the county executive for the second issue. Goes around to different community members talking about Housing First, our initiative. And really, the biggest thing is providing community education to reframe the conversation about homelessness, what it looks like, and what our policy should be. So it's a really important part to what we do. So that's what I have. I'm happy to take questions.
I have time for one question. Representative Sargent.
Thank you very much. So I have a two-part question, and if we don't have time for it, we can touch base after. But citing of Housing First initiatives is a challenge. We suffer from people who don't want these facilities in their neighborhoods. So how were you able to overcome that with your project? And is it, potentially something that can be replicated in other parts of Wisconsin? And additionally, the importance of having a diversity of stock. So you talked particularly about single individuals who are suffering from alcohol addiction, but we know, and the good doctor talked about this during her presentation, the importance of having housing stock that can have multiple bedrooms, because there may be a parent with multiple children who need their space so they can be successful in school. We need that diversity of stock. With your Housing First initiative, do you have that diversity? And how did you address that?
Sure. Excellent question. So for Housing First siting, again, a majority of the housing that we used for this initiative specifically is scattered site. So individuals choose wherever they want to live, just in the private landlord market. There's certainly a lot of tax credit developments done throughout the state. Thurgood Marshall was an example of that. The siting I chose for that, it was actually a formal correctional halfway house, very close to downtown. So if the downtown businesses wanted a reduction in homelessness for that specific population, we wanted to be as close to downtown as possible. But again, the land we chose was a formal correctional halfway house. We met with the neighborhood who really, really liked the service provider, but didn't like the halfway house. So we said, what if we kept the exact same service provider who's on your resident board, who does all the neighborhood safety watches and everything else, and we made them our on-site service provider at this location, and it's no longer a halfway house, but it's this. They actually showed up at zoning to support it. And a lot of them said, my uncle has similar problems like this, and that's when we had to be very invested in the neighborhood. My staff has to be present with neighbors, figuring out security concerns that have nothing to do with our building, neighborhood cleanups, whatever we have to do, whatever our clients can do for the neighborhood for cleanups, we do that. But again, most of our housing is scattered site, and it gets to the mix of units. But even in our affordable housing developments, we will mix 1, 2, and 3 bedroom units. But again, if communities are trying to make a dent in chronic homelessness quickly, you don't have to wait for new developments and construction and tax credits. If you give folks a scattered site voucher, they can be a lot more successful than you think if you have those wraparound services. Again, besides the case management, one other quick thing, my community intervention staff in the housing division permanently stays attached to every single residence on top of the case management they get. So landlords never have to even talk to our clients. They can call us directly if there's ever a problem in a unit. They just call our workers. We immediately go out there. I think in the 600 or 700 units, we might have had 3 or 4 evictions, which is far less than the regular population. But it's all that development we do in a relationship building with landlords. That if there's a problem, we'll take care of it. We'll move Joe somewhere else. We'll help him move. That's not a problem. It's all this connecting with landlords that's been successful. So you don't necessarily have to do housing construction, but you do have to have the subsidies to give to folks to find their own units.
Thank you for the presentation. I'm wondering about sober housing. Do you offer sober housing, or do your consumers ask for sober housing? And how do you deal with that with kind of mixing populations?
Excellent question. So very few of our clients ask for sober housing, but they do. And Milwaukee County does provide it. So again, the biggest thing, so Thurgood Marshall is a perfect example. So we have individuals that move into that building that are not ready for sober housing and don't want it. 6 months after that, they're clean, they're sober, they went to treatment, and they're living with folks that aren't at that stage of recovery and they want out. So we give them a scattered site voucher to move to their own apartment so they can work on their recovery outside of that milieu. So that's one of the things we do. The Milwaukee County Behavioral Health Division under DHHS does offer sober housing, so we'll go that route. That's supported by them as well. So our major focus is harm reduction type activities, but we can absolutely do sober housing as well. The more different types of housing a community has, the more successful you're going to be.
Well, thanks for that presentation, Mr. Mathy. And apologies for the format on that slide. We'll make sure that the version that's posted on our website is 219, not 21. That's one order of magnitude off here or there, right? And also apologies for the maintenance noise during your loud ghost, whatever that was. We'll move on. Our next speakers are Alan Sexton and Andy McMahon, both with UnitedHealthcare. Ms. Sexton is the Chief Executive Officer of the UnitedHealthcare Community Plan in Wisconsin, where she directs the strategic development and operations of the health plan, which serves 170,000 Wisconsinites through our state Medicaid program. Mr. McMahon is the Vice President of Health and Human Services Policy at UnitedHealthcare Community and State, which serves nearly 6.5 million Medicaid members in 26 states in the D.C. In this role, he focuses on integrating affordable housing and human services for populations with complex health needs, and he previously worked, among other positions, with the Corporation for Supportive Housing. Thank them both for being here today, and we'll take it away. Make sure you got the mic button there.
Sorry about that. Thank you for the opportunity to join you all today. And I think I want to start off by applauding Milwaukee. It's just incredible work. And if anyone questions it, feel free to call me and I can send you evidence that fills this room that proves that what he's talking about is absolutely right. So just a huge thank you for your leadership and the work you all are doing. As Sam mentioned, I'm with UnitedHealthcare, and we actually operate in 27 managed Medicaid health plans across the country. I'm going to provide a overview of what we're doing and what we're focused on in various markets, and then Ellen's going to do a deeper dive on what we're doing here in the great state of Wisconsin. But I think the first thing I would say is kind of we're a healthcare company, so why are we here talking to you all about housing? And I think my esteemed colleagues have already done a great job of talking about this, but I want to kind of highlight a few things. First and foremost is that, as Jim mentioned, housing is the necessary platform for healthcare. None of us in this room, none of our family members or anyone else will succeed in any host of other things without safe, decent, affordable housing as that foundation. And so as a healthcare company, as a managed care entities, we recognize that, and we have a whole host of Medicaid lives and Medicaid members that are in our plans across the country who don't have safe, decent, affordable housing. And what that means is that they have very poor health outcomes and they have very high utilization of healthcare services. And unfortunately, most of those services are emergency in nature and cyclical in nature and expensive in nature. And they're not preventative, and they're not the things that we really want to be focused on. And so this slide just gives you a quick overview. I'm happy to share all the data behind it, but it just demonstrates in part what Jim talked about, but the impact of getting people who have acute healthcare needs and histories of homelessness and housing instability into safe, decent, affordable housing has an enormous impact, most importantly on their health and their health outcomes, but also on their utilization of services. And so we've talked a good bit, and thank you, Dr. Curtis, for laying out, I think, a great kind of survey of the need and how acute the need is and how severe the need is in Wisconsin and across the country, which gives me the opportunity to really focus on what we are doing as a healthcare company to try to expand housing opportunities for our members, but also pursuing opportunities where kind of all boats rise for our members and other plan members as well. And so I'm going to go over briefly kind of the three-pronged approach we're taking to expanding housing opportunities. I would say at the outset that it's really important to know that these need to be integrated and we need to do all three of them. This is a really complex and acute issue. No one way are we going to get there from here. And the other thing I want to mention as we talk about this is that all of these things that we're doing are outside of Medicaid financing. So when I talk to you about some of the investments and other things we're doing, there's no Medicaid billing that comes to us or anything like that. These are investments that UnitedHealthcare is making as a company because we think it makes sense. But I think what I would argue is that kind of together over time, we need to work to kind of better integrate and align our public and private resources across housing and healthcare from primary and behavioral health and the other social determinant areas that we talked about. So first I'm going to touch on investments. And I'm happy that I was on the right page, I think, as I heard some of my panelists. So we have what I would call a five-pronged approach to our financial investments in affordable housing. The first is, and I think Ellen will probably talk a little bit about this too, but nationally we've invested over $400 million in low-income housing tax credit projects across the country, and all of that really within the last 10 years. Lots of folks came knocking on our door during the recession, and they were looking for more investors at that time, and we got engaged there. So we are doing very significant investment in LIHTC projects, low-income housing tax credits. We are also doing direct equity investments. The kind of flagship for us is a project in Maricopa County in Phoenix, Arizona, where we invested very significantly to rehabilitate 500 units of housing and to recapitalize that project and make more than 100 of those units affordable to our members, and then also benefiting the broader community with the rehabilitation of the other 400 units. So we're looking at ways to replicate that kind of direct equity investment. Thirdly, we're looking at developing something I would call kind of informally a health equity fund, but thinking about how could we put together an actual housing fund that would not be project by project, but might be seeded by us at $50 or $100 million and say, we're going to go out and make these equity investments in affordable housing projects that have direct connections to healthcare and health and housing and integrating those things. So it would be a way for us to expand our efforts in the housing investment side. Fourth, we are exploring and have done some work already in social impact investing and pay for success. UnitedHealthcare is the senior investor in a pay for success project in Los Angeles County called Just in Reach. And fundamentally, what we're doing there with our investment of about $8 million is helping to finance the housing and services for 300 people who are super utilizers who sadly ping-pong between the Twin Towers LA County Jail and Skid Row, which is about 6 blocks away from the jail. And our investment will be repaid based on our partners' ability to stably house folks, keep them stably housed, and reduce their recidivism rates. So we have an outcomes-based contract with the County of Los Angeles where we are at risk. If this project doesn't meet the projected outcomes, then we risk not getting repaid. But we feel strongly, that it's the right thing to do, and we're very confident based on the evidence that the program will be successful. And I think the stuff that Milwaukee talked about is case in point for that. And lastly, and somewhat connected, and Dr. Curtis mentioned this, I really want to emphasize this point, is these low-income housing tax credit projects that we've been referring to have a 15-year life cycle of affordability, a 10-year tax credit to the investors, and a 15 affordability period, we are looking to make investments. Those projects that are coming up on their 15 years are called quote unquote expiring use projects. So we are looking at putting together deals that will preserve and recapitalize that housing as affordable housing, so that as we're looking to build new housing, we're also not losing ground on affordable housing that we have. So I think that's a really critical piece of the work that we're doing. So that's a thumbnail sketch of our work on the financial investment side. Now I'm going to talk about partnerships. And these are not unrelated from investments, right? These are intertwined with financial investments as well. But one of the things we realize at UnitedHealthcare, right, is that we're acutely interested and are exploring how we can make investments in housing. But ultimately, we need great partners on the ground in communities in Wisconsin and across the country to get this work done. And so we are embarking on and have developed a number of partnerships with an array of entities. So we're working with public housing agencies that are providing Section 8 rental assistance and public housing and tenant-based rental assistance, as well as project-based rental assistance, like it sounds like is at Thurgood Marshall, and trying to think about how can we partner with PHAs, and we're actually part of a national initiative where we're going to be creating formal partnerships between UnitedHealthcare health plans and public housing authorities across the country, recognizing that you all are providing the rental assistance and the other things, we can provide the connection to care. And so we need to work much more closely together, is the short of that. Secondly, we're working with state housing finance agencies, and some of that could be around qualified allocation plans or QAPs, trying to push for prioritization of low-income housing tax credit projects that serve individuals and families with complex health needs and histories of homelessness and very low incomes. And so we are exploring ways we can work with the HFAs. Thirdly, we're engaging with continuums of care across the country, as also was alluded to in Milwaukee, not only with the housing authority and the housing agency working together, but also working with the local continuum of care, right, which is consisted of a whole host of the homeless service providers and supportive housing providers and owners, that our residents, our members really need to be connected to because they can be their residents. Fourth, we are working with Healthcare for the Homeless. Healthcare for the Homeless, for those of you who are not aware, is a remarkable organization. They exist in not every community in the country, but in lots of them. And it is an amazing combination of individuals who have actual medical skill sets and can provide some degree of medical care, but also have the ability and the guts and the chutzpah to go in and under the bridges and in and out of shelters all around downtowns and engaging with people and taking the time that it takes, which is a lot of time, to build trust for people, many of whom have had a lot of relationships that were not trustworthy. And so that building of trust is huge. And we recognize that our community health workers can be a part of that solution, but they don't necessarily have that exact skill set. And so we're looking to partner with Healthcare for the Homeless. We're also creating partnerships with affordable and supportive housing providers across the country. Dr. Curtis mentioned, with such a huge lion's share of this that is not necessarily publicly assisted. Our housing in our country is largely a private market endeavor. And so thinking about even in the private market where we can work with our members and connect them to housing. And finally is in plans across the country, we are hiring housing navigators on our own staffs to help people navigate the complex web of applying for various voucher programs or trying to help get and talk to the landlord and get into that unit that there might be some question about. And so that's kind of a overview of the partnerships that we are creating. Again, we can do a lot as UnitedHealthcare. I think we have enormous ability on data and analytics and provider network creation and all those sorts of things. But we're going to need all of these partners and more to make sure that all of our lives and all the members that we serve have a safe, decent, and affordable place to call home. The last piece I'm going to touch on is on the policy front, and I focused here on the Medicaid policy front. I will say we'll be doing other efforts around housing policy, supporting efforts around Section 8 vouchers, changes to the low-income housing tax credit program that could expand the basis of but the money that could go in for very low-income projects. So we're doing other things on the housing front. But on the specific to Medicaid, we are working on in a few primary areas. One is around 1115 waivers that states put forth to the Center for Medicare and Medicaid Services, CMS, and looking at an array of waivers that can help us expand the connections between housing and healthcare. And one of those is waivers that we've been supportive of in a few states and are looking at others where that would make kind of what we call quote unquote tenancy supports a Medicaid billable service. And so those are some of the kind of case management services, the things that we're talking about, the engagement of these folks that right, fundamentally anyone that has worked with a lot of these folks, those, trust me, are medically necessary for these folks, but are not necessarily seen that way kind of nationally in the eyes of CMS. And so we're working on waiver changes so that we can create a more comprehensive and sustainable financing system for those types of needed services. Secondly, we're working on whole person care pilots in a number of states around the country that are trying to endeavor to kind of create these connections across not only healthcare, but housing and all the array of social determinants. And as the title suggests, kind of taking a whole person approach to this that is expansive of just their healthcare. And then the last but not least is exploring opportunities for value-based purchasing, right? Where there's a push for, I think rightfully so, to think about how do we pay less for volume and the number of times you do something versus the value or impact that something has on somebody's health outcomes. And so we are exploring opportunities, and that's a very complex issue, but we're exploring opportunities where we might be able to enter into value-based contracts that could also help our efforts to integrate housing and healthcare. So with that, sorry to race through, but that's kind of a quick thumbnail sketch of what we're looking at nationally, and I kind of I aim to go broader rather than deep because I thought it was most important, I think, and I'm happy to talk to anyone afterwards, but to understand, at least from where we sit at UnitedHealthcare, that it has to be this multi-pronged approach. Like, we can't do one thing. We can't say, oh, we're not gonna buy our way out of this housing problem. We're not gonna partner just our way out of this housing problem. We're not just gonna change policy to get our way out of this problem. We're gonna have to work together and work across all of these and other strategies. So thank you. And with that, I will turn it to my colleague, Ellen.
Well, greetings. It's great to be here today among legislators, policy experts, community partners to talk about this important connection between health and housing. As Sam mentioned, I'm Ellen Sexton. I'm CEO of the UnitedHealthcare Community Plan in Wisconsin. That means that I, alongside my team, have the honor of serving 170,000 Medicaid beneficiaries here. At UnitedHealthcare, I think you can tell from Andy's overview, our mission is to help people live healthier lives and to help the health system work better. And if you think about the U.S. healthcare system right now, it's hard to navigate. There's rising costs. There's tens of millions of people that are still uninsured. And even though we spend twice as much as other developed countries, people are still not getting the health care that they need and deserve. So at UnitedHealthcare, we're thinking about that different. And one of the things is not to just think about the clinical conditions, but to talk about the social determinants, the things that are impacting people's quality of life, their economic situation, their job, do they have access to food, housing? These all matter to us. And as you can see, we can impact them and actually reduce healthcare costs as we do that. So Andy mentioned about a lot of the financial investments that we've been making across the nation, and I'm proud to say in the last 6 months, we've also made some here in Wisconsin. So the flats at Grandview Commons, that's on the east side of Madison. It's a 96-unit affordable housing unit. We invested $5.3 million from UnitedHealthcare. We worked alongside numerous partners. This is a true takes a village to bring things to fruition. So WEDA, Minnesota Equity Fund, and Senair were part of that. And then more recently in February, we broke ground at 704 Place. That's actually in Walker's Point. So Representative, I know, had to step out, but right in the area that we were talking about. And the awesome thing about 704 Place is that it has 60 units, but 14 of those units, I should say, are set aside for veterans and people that have been struggling with homelessness. In addition to that, it's not only about the affordable housing piece of it, but it's the wraparound services. There'll be on-site service support for them, case management to truly help those veterans and those that were homeless to get back on their feet and lift them up out of poverty. So as Andy said, we've been doing that across the country. We've invested over $350 million since 2011. We've brought 2,700 new homes to families. That means there's more safe and affordable housing for people to access. And I think it's a really unique and different way of thinking about how you can bring private and public together in housing and healthcare to make a difference. So Sam, I think, already showed these numbers to you, so they should look familiar. But what I want you to think about as I talk through this is that health is impacted more than just clinical performance. And so when you look at the right side of this slide, of course it's clinical care, access, and quality care. Yes, it's your physical environment and your healthy behaviors around diet and exercise. But take a look at the left side. 40% is due to social factors. Do you have a job? Do you have access to quality food? Do you have transportation? Do you have safe and affordable housing? So many times I go and visit my members and it's a pregnant mom and she's couch surfing. Imagine being pregnant and not knowing where you're going to be living next week. You have a lot to deal with. That shouldn't be something that you need to deal with. So when we think about our case management, we focus a lot of our time, especially up front, on those social and economic factors. And I got to tell you, the case managers on my team, they're amazing. And it is about developing trust and getting people into the care they need. So our community health workers, Andy mentioned our whole person care model, and that really is getting out door to door, face-to-face visits, because a lot of these people have complex conditions and they're homeless, and we can't reach them unless we're going face-to-face. So meeting them where they're at is really important. And if you think about traditional Medicaid and the provider environment, a lot of health isn't happening in the doctor's office. It's in the environment that they're in. So think about somebody who comes out of inpatient. They've got a discharge plan. Maybe they don't even understand what they're supposed to be doing. That's what our caseworkers are helping them do. And so you think about some of the conditions that somebody who's homeless is dealing with, right? So they could have poor air quality for an asthmatic, or a diabetic who doesn't have refrigeration. I have a story of one of my case managers. She went immediately home when she found insulin that wasn't being refrigerated, got a cooler, filled it with ice, and made sure that that insulin was now at the right temperature. Think about somebody coming out of an inpatient stay. They don't have food at home. They may not even have a home, right? So we have a program for our readmission reduction, and that all centers around making sure that people have 7 days of meals shipped right to their home. So all these things are creative ways of thinking differently about how we spend the money for healthcare, but also get better outcomes for the people that we're serving. So a big part of solving for this is the wraparound services that Jim talked about and case management. I wanted to spend a little bit of time talking about the My Connections pilot. So I wanted Andy to come today to tell you about some of the great programs we have across the nation. And what I get to do is bring that to Wisconsin. And so for the My Connections pilot, it really is the housing first notion that we talked about before. And if you think about people that are homeless, they are spending and overutilizing the wrong types of healthcare, so emergency type visits, and underutilizing the right type of healthcare, so preventative care or mental health. And they're difficult to case management because half the time we can't even find them, right? They're transient and tough to locate. So if we start with the housing first approach and use that as a first access to get them back on their feet, the rest of this all follows. So what we're doing in Milwaukee is we're taking 10 individuals that have high utilization of preventable healthcare costs. So you're talking about $120,000 to $150,000 a year. They've got an average of more than 28 ER visits a year. And what we'll do is start with a housing first approach. We've been partnering with Milwaukee County Housing Division, working with landlords. We get them in housing. We then get all the social services wraparound, SSI, SSDI, get them Section 8 housing, and worry about their social services first. Then with our case management, we can get them access to care, mental health, and really get them back on their feet. The goal in the end, right, is to get them to self-sufficiency. So we'll be subsidizing this rent, just as Jim talked about for a lot of the folks that they worked with as well. And if you think about that math equation, it's not hard. So $700 to $800 a month in rent, $10,000 a year versus somebody that's costing $150,000. So that's the math part of it. Now think about that individual that's back in society, functioning. I was actually at the Thurgood Marshall Apartments. I think it was in January now. I know it was winter because it was cold. And we met somebody who had been living on the streets for 16 years, now was there for the last year. And he told me about how he had ridden his bike to his grandkid's birthday party. And he was talking about how he wanted to start looking for a job as a machinist. So you can save healthcare costs, yes, but we just returned somebody to living their life. And I can't think of anything more powerful to be part of. So I want to thank the Milwaukee County Housing Division. Your team's been phenomenal, and I think a lot of your goals align with our goals. So on behalf of the 9,000 other United Health Group employees that work in Wisconsin, I hope you can see how proud we are to be working in this space at the intersection of healthcare and housing. And then I ask you to help join us as you think about policy, as you think about how to partner with us to really help solve this. Thank you.
Representative Sargent, you have a question?
So you touched on this a tiny bit, and I don't know if I'm jumping ahead, and maybe you're going to talk about this in your presentation, but I'm wondering about the cross-pollination of MA dollars to not just pay for healthcare, but also because we're able to see data-driven how housing has a direct impact on healthcare. And are there waivers that have been successful across our nation that have been able to be used for healthcare that maybe we could be doing pilot programs or bringing more light onto that as a possibility here in Wisconsin? And again, if I'm stepping on a presentation that hasn't happened yet. Okay.
Are you going to talk about that? Go ahead.
Okay. So I'll be very brief because I'm guessing she will. But I think so. The short answer is yes. Right? I mean, I think if you look at the statute currently, like it pretty clearly says that Medicaid dollars cannot be. The federal Medicaid dollars cannot be used to pay for rent. And so what we are doing, though, that's where I mentioned both in terms of the 1115 waivers that I think are worth looking at in terms of opportunities to expand the array of services, but that also can include, what that also includes is what we'd call like housing-based case management. So that also includes being able to go and talk to the landlord, to do the work that the VHA does, and so that are kind of non-traditional from a Medicaid perspective. And I would also say the other area where we're looking at that is around through some of these value-based purchasing agreements, where what is it that we can pay for as a healthcare entity, and kind of how can we structure things and focus them on outcomes and how that might align with them also being connected to the housing and then also the healthcare they need. But I'm sure she'll speak to it as well.
Thank you.
Thank you very much. So finishing up with the representative's question, in order to request those waivers for case management, there needs to be political will and the money. I mean, are you familiar with states that have not accepted the expansion, that have the room in their Medicaid plan to be able to afford requesting a waiver for a wraparound? And then I have another question after that.
So I may have to get back to you. I think that I think the states that I'm at least currently working with are expansion states, quite honestly, that have done that in terms of where. But I think one of the things that would be interesting, I think, though, even as you think about your own caps, is kind of looking at the cost benefit of that, right? Of saying, it might cost you this, but like honestly, what I would say is that when you're talking about these very high utilizers, even if you're then saying up front you're going to finance this cost, on the back end of that, for these folks for whom these services are critical and absolutely medically necessary, I think there's evidence that you would see return on that investment that you made.
Well, I appreciate that, and we're very, very grateful for the examples that we can show in Milwaukee right now where permanent supportive housing does work, and where, in fact, for those projects where we need that investment and we can't find it, the Medicaid waivers would be perfect for that, which leads me to my other question. Are you familiar with projects like these that have worked in rural areas where we don't get the scoring on the QAP because we don't have transportation, the projects aren't close to playgrounds and shopping centers and hospitals, so the projects don't score enough to be even able, and what category do you put them in? It's have you looked at our QAP?
Just a little bit, and I haven't studied it, but
Okay.
yes.
Okay.
So, I think what I would say, I don't think there's no silver bullet there, quite honestly. You're absolutely right. And I think in rural communities across the country, in every state that we have a health plan, you have that need, right? Not only in that kind of additional problem, because not only do you have kind of on the housing side, right, kind of how many units and those sorts of things, but on the healthcare side, you start thinking about kind of time to deliver services and all those issues. So I don't have a great example for you. I'd be happy to follow up. We are doing some work in Hawaii, which honestly, so there's parts like Honolulu, but then if you go out to other parts of Oahu and other parts that are kind of more remote and rural, and where we're looking to work actually with the Housing Finance Agency there, and particularly on Oahu. So I'd be happy to follow up.
I'm sorry, I'm going to take 10 seconds to answer your question. So I don't necessarily want rural communities to compete with us for tax credits. However, the subscription for the 10% set aside for supportive housing barely gets filled. If rural communities, you're correct with how hard it is for rural communities to compete, but if you were to provide a rent voucher for every one of the units on a project-based situation, you would get your tax credits.
Okay, where do you have a magic porridge pot that spits out these housing vouchers?
No, you'd have to
Where do you get them?
Well, you'd have to work with WIDA and smaller housing authorities.
Yeah, because the rural housing authorities, we have 10, 15-year waiting lists right now. And the other problem are developers. We just cannot get developers in rural areas for vanilla projects, let alone,
That shouldn't be a challenge. But we could talk later. Sorry.
I'd love to keep this conversation going, but we'll finish up with a view from Sandy Brekke, who serves as Senior Consultant to the Office of Population Health at Gundersen Health System in La Crosse. She received her undergraduate degree from UW-Madison School of Nursing and is pursuing graduate work in servant leadership at Viterbo University. She's been director of the St. Clair Health Mission, a free clinic for low-income and uninsured individuals in La Crosse for 12 years. And she serves as strategist for Gundersen's work on housing and homelessness prevention, as well as other community-engaged and trauma-informed initiatives. So thanks for being here today. Take it away.
Thank you. Well, so I'm not the housing expert in the room. I come from healthcare. In fact, my background is director of a free clinic, and if you know anything about social determinants of health and free clinics, 100% of our patients fall under the poverty level and are uninsured. And so they come with them a myriad of issues all related to the social determinants of health. And if you are looking for some of the solutions, go to your free clinics because they've been doing it for decades. They know that you cannot take care of patients if they're not housed. They understand nutrition and they're on the ground and they're doing this work and they have a lot to teach us. I love to show this slide, just give the UW Institute of Population Health a little bit of kudos. I think what is so prominent in this slide is that clinical care is 20%, but where does all of the funding go? You know, we are a nation heavy on sick care. We do it incredibly well, but the rest of that stuff we really are struggling with. The other thing I love about this slide, and that you don't see in other slides necessarily looking at population health, is length of life is 50%. But quality of life is 50%. In healthcare, we tend to focus on leading causes of death. Population health, what if we focused on the leading causes of life? How would we look at healthcare differently? And that's where we're going with population health at Gundersen Health System. It's moving healthcare upstream. And so everybody in population health around the nation is going, oh God, what do we do? How do we do this? Some of it is, you know, some health systems I've talked to are looking at population medicine. So it's disease states. It's are we checking hemoglobin A1Cs on all of our diabetics? And are we managing quality by disease? We are looking at it very, very differently at Gundersen Health System. We are looking completely outside our walls because what we know is by the time they get to us, oftentimes there's already an issue and we want to try to prevent that. So how do we do that? And one of the ways the ways that we do it is we have to identify systematic patterns and what's happening and their variations. We're looking at a ton of data, constantly analyze data. We have a brilliant epidemiologist at Gundersen, Dr. Rooney, who can pinpoint neighborhoods where police are going, where we have truancy issues, where we have health issues, where we have lead in the homes. We have an abundance of data in healthcare. But what we are struggling with is how do we get out and do this? And in part because we're not funded to go out into the community and do some of this stuff. But really, healthcare has to create systems of health. And if we are moving to a value-based system from a volume-based system, this is imperative that healthcare moves outside our walls. Primary essential function of housing is to provide a safe and sheltered space. What the data shows and what the American Medical Association has said is, you know, the top 5% of ER utilizers use 50% of healthcare dollars. So what we did is we pulled our 100 top utilizers of the emergency room at Gundersen Health System, and then we actually focused in on the top 20 because they were incredibly high users of dollars. And what we found was almost all of them had been in and out of housing. An obvious target for us to go after in population health is housing, but how do we do that? Some of our other initiatives in population health is we're definitely looking at opioid issues. We are part of creating a community pathways hub, which I'll talk about just briefly here, but this is essential for social service systems to come together in communities and not work in silos. ACE and adverse child experience and trauma-informed care, I think, is the root of a lot of our issues, and so we're heavily investing in adverse child experiences and becoming a trauma-informed community. So looking at housing, what was really interesting is prior to my working at Gundersen Health System, I saw a 60 Minutes show with this crazy group in New York City called the 100,000 Homes Project, decided to house 100,000 of the highest risk homeless in the country, and they did it. And what was super interesting about it is they did it using the same strategies that we're using in quality improvement science in healthcare. And so when I came on to Gundersen Lutheran, one of my VPs had already heard Erin Healy talk, and we said, well, let's bring her. Let's bring her to La Crosse and see what she has to say about our community and if she can help us with our issues with housing and homeless. La Crosse is small compared to Milwaukee and Madison. We're on this side of the state that tends to get forgotten a little bit. But we are in La Crosse. If you look at Madison to our east and Eau Claire to our north, and then you're down into Iowa, we are the center for the homeless. So those homeless that are out in the rural areas are coming to La Crosse. So we have a higher homeless population than what you would think for the size town that we live in. So this was not hospital-led because we are not experts in housing, and I know that, and we all readily admit that. Population health is using the resources of the health system out in the community to really be the accelerator, the jet fuel behind projects that are already happening or struggling to take off. What can we use? How can we help with our resources to get things going? We already had a coalition around homelessness in town. We brought in Erin Healy, and it evolved to the La Crosse Collaborative to End Homelessness, setting goals to end homelessness in La Crosse. It's really been an amazing process to watch. This is an action process. We are not having conversations anymore because we know the issues. So we are moving. We are doing 100-day sprints to house people, and we do not let ourselves fail. It is innovative. Nothing is as is around housing in La Crosse and around our homeless. And celebration. This has been really tough work. A lot of people are putting in tons and tons and tons of effort. Ours is mostly private, nonprofit sector. Public has joined us, but this is really being driven by our nonprofit sectors in La Crosse. These are all of our partners, and we couldn't do it without every one of them. We have foundations, the police are with us, court systems, we have all of our shelters, the Y, health systems, we have our nuns. When you get the nuns praying for you, you know you're on the right track. So we started out with veterans homelessness. Our goal was to end veterans homelessness in 100 days. This was our first sprint. We all kind of thought we were crazy, but Erin Healy cheered us on. We worked with the Department of Veteran Affairs, and we had 16 homeless veterans that we knew about. We housed them all within 100 days, which was a 400% increase in the housing placement rate for La Crosse. Since then, we've housed 42, 93% remain in stable housing, and we are just about at functional zero with our veterans. We were the first city in Wisconsin to end veterans homelessness. So we were recognized on we're certified by the United States Interagent Counseling on Homelessness. Second sprint happened July 2017, which was our chronic homeless. We housed 20 of our highest risk. To date, we've housed 32 and 94% remain homeless. We are working on functional zero with chronic homelessness as well. Our sprint 3 was families and children, which I wanted to start first as a healthcare provider because it seemed like the most obvious thing to get children into housing, but it's incredibly hard to house families. There are not the resources around families that there are around the chronic and the veterans. So it has really been a challenge. Our goal was to empty out our Salvation Army homeless shelter of children, and we made that goal. So we housed all those families, and our goal is to not let any more children hit our shelters. Because in healthcare, what we know is we can predict the trajectory of a child's life. In fact, in population health, I think we should just tie our health systems to our schools, because one of the biggest predictors of the outcome of someone's health throughout their lifetime is a kindergarten teacher. So our schools are huge predictors of health, and they are not places that healthcare is looking. And what we know is that if a child hits shelter, their trajectory of life unfortunately can be predicted. And this is trauma, there's all the things that go along with that. So our goal in La Crosse is we don't want any more kids in our shelters. I mentioned this a little bit ago, Grace Hub. So we don't have a lot of public resources necessarily to do this case management. So part of another one of the projects that this is intersecting with is this Community Pathways Hub. This is a model, evidence-based model that's coming out of Ohio. It's being looked at, I know, here in Madison, and I think in Milwaukee is starting it as well. It is, in a nutshell, it is air traffic control for the social service system. We are referring people into the hub, and there they get a case manager from multiple different organizations in town. These case managers are all following the same pathway. So assessments are similar or the same across the community. People are assigned pathways, which are problems, and we are getting to the end of those problems. This is a braided funding initiative where the organizations are actually funded and paid by outcomes. So there is a pathway for housing in the hub. So when we have a high utilizer to an emergency room, we can refer them into the hub. They work with the Collaboration to End Homelessness with their care coordination people from the hub. When that person is housed, that agency is actually reimbursed for that outcome once they're in housing for 90 days. So we're using the Housing First model, but this is another way to reimburse the organizations who are case managing the people who are helping keep people housed. And this consists of public health nurses, social workers that are on the ground. We have community health workers as well. So all those people are out on the ground, meeting people where they're at, working on keeping them housed. One of the things La Crosse has done is we've joined Built for Zero, which is a national movement on ending homelessness. It's an incredible performance tracking tool. So we know exactly where everyone is at all times. We know exactly what our inflow rate is. We know what our outflow rate is. We are measuring the length of time homelessness. We know what houses are coming up next. So it's just as great for someone who's kind of a data geek. This is really fun for me to watch how well we're doing. And what it allows us to do is it allows us to shift course. So if what we're doing isn't working, we can see it real time and we can shift course, which is really important for a lot of the work that we're doing. And it shows our cost effectiveness across all sectors. This is a slide that actually is used by the 100,000 Homes Project. It's coming out of Skid Row in California, which just shows some of the cost to saving lives and public dollars. So it costs $63,000 to keep someone homeless. In California, $16,000 to house them. And it's even cheaper in La Crosse, and we're working on that. And this slide actually makes a big impact on people. And it did on, a lot of this is changing mindset in our community because, like James said, we have an incredible town. People actually love to donate to our shelters and volunteer at our shelters. And our goal is we're going to close our shelters. And so one of them will probably change to bridge housing and the other one's going to close down because that is not how, number one, it's not cost efficient, but more important to that from a health system, this is a social justice issue. And as a health system, this is how we are looking at this. These are just some numbers we have from La Crosse. So we're starting really just to get initial data. We know what it costs in La Crosse. So now we're starting to follow people over time to actually see what the cost savings is. We have one person who is actually in the hub, was housed, and we've been tracking for, I'm going to say 6 months, but don't hold me to that. And we have 23 fewer visits to the ER this year than we did last year. So at a rate of $1,200 for an average ER visit, that is already showing cost savings to the health system. The solution really to the homeless issue is we have to infuse money into upstream prevention. And that's where we're moving. We are changing our system from a crisis system, and we're really putting resources into upstream prevention so that over time we can decrease the more expensive downstream system. So this is really important to what we're doing, is really shifting that funding. Dr. Curtis talked about the shock to a family. Our goal is to fund that shock. We don't want those shocks because we don't want any families losing their housing. And so we have, we're creating systems and money and lots of work going on so that we don't have families who are entering the homelessness. And I went really fast. I was trying to keep watching the clock here. So housing is healthcare. You can't argue it anymore. There's too much data and too much research out there to show that if we do not house people and we do not have people in secure housing, we cannot provide our best healthcare. And so health systems have got to get into this arena in some way, somehow. I think every community has to use its own creativity, but we definitely need help from policymakers. We are saving Medicaid money. We need these policymakers at the table really looking at this issue, looking at all sectors. We're saving jail, we're saving police, we're saving, all sectors are being impacted. And in healthcare, we look at the triple aim, and one of them is to lower costs. Well, maybe we're not always lowering our bottom line, but if we're lowering the bottom line in the community, then we are impacting the cost of healthcare. And this is how we are looking at this at Gundersen Health System.
Well, thanks much for that. We're running right up. Yeah. I know we're running right up about noon, but if there's any legislators at the table have a question, we can probably squeeze one more in. All right.
And perhaps Representative Billings can answer this because I know that she's at the heart of what's going on in La Crosse. But how in the world do you manage sharing of records and privacy and HIPAA? There's so many agencies when you were talking about that. How did you do that?
So the hub has a community-wide release of information that all agencies and organizations, believe me, and our attorneys from health system all sat at the table to create a community release of information. Mm-hmm. How long did that take? It took a long time. But that is being, so these community pathways hubs, that's part of what they're helping drive in communities, because it is really imperative that we share data across systems.
Well, I wish we could take more time with the panel, but I know everyone has. Oh, absolutely. Yeah.
Yeah, Representative Jill Billings from La Crosse, and thank you for being here, Sandy. I've been educated by the people through the health department, United Way, the hospitals that are working with the hub. For those of us in the building, Representative Bob Gannon and I had been in conversation, unfortunately, before he passed away, with the Urban Revitalization Committee. Now, Bob is a Republican, was very interested in this model and working on bringing it to La Crosse. I know Representative Fields, who took up the baton, is interested in learning more about the hub, and had a conversation planned with all of us in La Crosse and wasn't able to attend, but is interested in bringing this to Milwaukee too. It is incredible work that's being done, and it benefits so many people that you maybe don't even think about. I was just at a session with our fire department, and they're looking at focus groups in the community on how they can do services better. And we talked about the hub, where they're called out on calls for people who may have mental health issues and they're lonely, or they have other issues, and they decide, I'm going to call 911, I'm calling the fire department, and the expense of all of that, where, and it's like emergency rooms. Why do we have our fire department going out in these frequent calls when we can better help people through the hub and have social workers and people get them the services they need so that they're able to get services in a better way than those broad ways of entering the emergency room, calling fire departments and issues like that. So I think it's a great model, and we need to be doing more. I know Madison is. I think they have a hub already, don't they? But it's a great model for the state, and thank you for your work on that.
Well, thanks for those comments, Representative Billings, and thanks to all of you for being here today. With that, we'll bring today's briefing to a close. If you haven't done so, pull out those yellow sheets, drop them on the table on your way out. All presenter materials and video will be posted on our website and emailed out to everybody, so make sure if you signed in to leave an email, a legible email, please. And stay tuned for upcoming briefings and other events here at the Capitol and elsewhere in the state. Thanks to our panel, to Representative Zamarripa for opening comments, and all of you for being here today. Thank you.